Hi, everyone. Welcome to another segment of Wednesdays with Wendy. I am Wendy Garvin Mayo. I am the founder of Shape Partners. I'm so excited tonight because we have a guest speaker, Dr. Lynn Elchin, who is also a certified hospice and palliative care nurse with over 40 years of experience in nursing in academia, as well as the clinical setting. And tonight she is here to talk to us about what caregivers need to know about palliative care. So with that, I'm going to hand it over to Lynn. Thank you so much for being here.
All right. Well, Wendy, I want to move myself so you don't see my kitchen doorway over there. I want to thank you, Wendy, for welcoming me and asking me to talk to your virtual caregiving community. And I'm very happy to have this opportunity to talk about palliative care, which then, of course, is going to lead into hospice care. And I know that there are a combination of professional folks and lay folks in the audience tonight, so that I do hope that I can hit a happy medium with the information that I'm about to present. If there are questions, please feel free. Wendy would like to have them at the end, but please feel free to type them in, and we can answer them then at the end. So the first, what I plan to do tonight is to talk about palliative care, to talk about hospice, and then really to talk about communication and caregiver, patient, healthcare provider / physician communication. And again, if there's any questions, please feel free to type them in for Wendy, and we can address them towards the end. So the first thing I want to talk about is palliative care. And I'm sorry I'm looking up and down, but I do have specific notes. And the first part of this information comes from the Center to Advance Palliative Care, which is centered out of New York City. And according to this group, this organization, which is a nationally recognized group to enhance palliative care and encourage palliative care within healthcare settings, is that approximately 90 million Americans are living with serious illnesses. And that number is expected to double over the next 25 years because of the aging population. The baby boomers, me included, will develop and have serious, at least one or more serious illnesses. Approximately 6 million, that's with an M, 6 million people in the United States could certainly benefit from palliative care. Palliative care is considered a medical specialty, and it focuses on improving the quality of life for people who face serious illnesses. And palliative care provides relief from symptoms and the stress of these serious illnesses. The goal of palliative care is to improve the quality of life for both the patient and the family and or the caregiver. It's all one. And the goal is to improve quality of life. So palliative care is provided by an interdisciplinary team of palliative care specialists. So the interdisciplinary team consists of a medical professional, nurses, social workers, could be other therapists such as psychologists. It can be physical therapists, respiratory therapists, occupational therapists. A whole group is dedicated to working with the patient and the family and the caregiver. So palliative care is appropriate at any age, at any stage of a serious illness, including right at the time of diagnosis. And it can be provided along with curative treatment. Okay, this is a big thing. Palliative care is to look at and treat the symptoms of this condition or illness, and curative treatments can be provided at the same time. It's not one or the other. So there was a study done, and it was published in the New England Journal of Medicine, which is a very reputable publication. It was done, unfortunately, it was done 10 years ago. But what it showed is that patients with lung cancer who were receiving palliative care had less depression, had a better quality of life, and survived an average of 2.7 months with against those who did not have palliative care. So 2.7 months is an average of extended life. That may not seem like a lot, but if you're the person or if you're the caregiver, that can really be a significant extension of life, especially if it's at an enhanced quality of life. So there are a variety of illnesses that palliative care can treat, and those include heart disease, cancer, strokes, diabetes, renal disease, liver disease, Parkinson's disease, Alzheimer's disease. There is no one illness that palliative care is specific for. It's anyone who's diagnosed with a life-limiting chronic disease. Approximately 68% of Medicare costs are related to people with 4 or more chronic conditions, and that is an ideal person who should be involved in a palliative care with a palliative care team. To date, there are over 1,700 hospitals in the United States that have formal, official palliative care teams. Certainly, we'd like to have that more, as it is for hospitals that are 50 or greater beds. Only though that's 61% of those. So again, it's increased dramatically over the last 10 to 15 years, but there is a lot to go. And I know here in Hartford, where I used to work, there was an inpatient palliative care team, but if you were an outpatient, there was no access to the palliative care team. So they were currently, when I left, they were currently working on developing an ambulatory setting, a palliative care outpatient clinic. So that would just be a wonderful addition to their palliative care team. Okay, if palliative care was used to its fullest potential nationwide, a total savings of $6 billion with a B, billion dollars worth of healthcare savings could be realized. So it does behoove the United States, the healthcare teams in the United States, to look at developing palliative care teams. Okay, so now that I've kind of given you a little statistics, what is palliative care? Well, it might be called palliative care or palliative medicine. Palliative medicine is a specialty that physicians actually study for and take boards to qualify them to be considered palliative specialists. It's a medical specialty that focuses on people living with serious illnesses. It provides relief from symptoms and the stress of serious illnesses. Whatever the diagnosis, whatever the prognosis. The goals are to improve the quality of life for both the patient and the family. Okay, that they're always seen as one. Patient and family and it's whoever the patient identifies as their family or as the caregiver. It's always seen as one. Again, any age, any stage, any serious life-limiting illness. And so, who can benefit from palliative care? Well, again, it's anyone who is suffering from a serious illness, whether it's cancer, heart disease, respiratory, kidney failure, Alzheimer's, AIDS, ALS, multiple sclerosis, anyone. When is palliative care appropriate? From the point of diagnosis. It is not dependent on prognosis or curative treatment. Okay, so really at the beginning of a diagnosis of a chronic or serious illness, it's appropriate. So why would someone want to be involved in a palliative care team? Why would a patient and family want to consider palliative care? You've got enough specialists, you've got enough physicians, doctors, therapists, all involved in the treatment. Why a palliative care team? Well, because these individuals are specifically trained to deal with complex symptoms and complex pain syndromes, which oftentimes accompany some of these chronic conditions. So some of the symptoms that can be treated by palliative care, by the palliative care team, include shortness of breath, cough, nausea, vomiting, diarrhea, constipation, hiccups, itchy skin, anxiety, depression, fatigue, loss of appetite, difficulty sleeping, and then always pain. So there's just a whole bundle of symptoms caused by either the disease process itself or the treatment for that disease. And that's what palliation is. It's palliation of the symptoms. It's treating of these symptoms. It's not treating of the disease itself, but the symptoms that either the disease causes or the treatments cause. So can you have curative treatment with palliative care? Yes, indeed you can. And so for the cancer patient, which is specifically Wendy's group here, yes, you can have palliative care that goes along with curative treatment. So it may be either surgery, chemotherapy, radiation therapy, all those kinds of treatments can be used in conjunction with palliative care, which is the palliation of symptoms that are caused by the disease or the treatment itself. Do you have to give up your own doctor when you go and use palliative care? No, you don't. Your primary care or your primary specialist works in conjunction with the palliative care team. Okay, again, it's a blending of, it's the specialty of the palliative care folks recommending treatments for the symptom management. How's palliative care paid for? Well, most insurances, including Medicare and Medicaid, include coverage of palliative care services. And how does one go about getting palliative care services? Well, you go through your primary physician or the physician who's being the main person directing your care for your disease process. You go through them and ask for a referral for palliative care. Okay, so again, that's here in the United States. If you look at the World Health Organization, and they have very similar definitions of what palliative care is. Palliative care improves quality of life for patients and their family who are facing the challenges associated with life-threatening illnesses whether that's physical challenges, psychosocial, spiritual, or cultural difficulties. It always includes the caregiver as well, even worldwide. That's a tenet of palliative care. Each year, it's estimated that 40 million people worldwide could benefit from palliative care. 40 million. And what the World Health Organization wants to have us know is that the early delivery of palliative care reduces unnecessary hospital admissions and the use of unnecessary hospital services. Okay, so it extends life, it decreases unnecessary hospital admissions, and it decreases the use of valuable healthcare services. So that's worldwide. Again, palliative care is a range of services led by professionals who are educated and proficient. They're experts in the palliation, of services, supporting the person and the caregiver. And so, they talk about the majority of needs. The majority of adults who need palliative care have cardiovascular disease. This is worldwide. Cardiovascular, cancer, chronic respiratory diseases, AIDS, and diabetes, according to the World Health Organization. Okay, again, a great need for palliative care services, not only in the United States, but worldwide as well. So one of the things I wanted to just say again is that, palliative care addresses the emotional, the physical, social, and cultural needs of our patients. It's comprehensive of the patient and family, whoever the patient identifies as family. So that if we have a control of symptoms, hopefully that leads to greater comfort and a greater quality of life for not only the person, but the caregiver and loved one, all other loved ones and family members. I mean, you can think of anxiety for one as one symptom. Even if we think of all of us as a group and our anxiety as it relates to COVID-19 over the last 6 months, think about how we might how palliative medicine might address anxiety, not just with medications for anxiety prevention, but think about all that we can talk about as healthcare professionals, as palliative care, with looking at how can we decrease the anxiety related to COVID. Well, that might be because of isolation. It might be because we're not able to go out into the normal shopping, working, visiting world. But I might be able to say, geez, as what kinds of things do you usually do to relieve your anxiety? Well, I like to read. I like to watch movies. Well, let's get the adult children together to give mom and dad a subscription to Netflix so that they can, watch old movies. And so what else, how else can we reduce anxiety? Well, it might be telephone calls, it might be Zoom meetings, whatever. So again, even as something as not as simple, but as common as anxiety is to all of us, I don't need to prescribe medication, but I can help that individual who has that diagnosis to use all different kinds of supports within their family, within their home. What about gardening? What about cooking? What about writing or life review to improve the quality of life, to decrease anxiety and improve quality of life? So, I think that it's really important to take a look at palliative care and to ask healthcare providers, your physicians, and I'll get into that just towards the end. So, palliative care does not include specifically hospice care or end of life care. Hospice includes palliative care at the end of life. And so there's a distinction between those two. So I just want to talk just a little bit now about hospice, and that, hospice is a philosophy of care. It is not a place of care. It's a specialty that we use when there is a prognosis for the patient of living 6 months or less. And so hospice does include the management of symptoms, physical symptoms, but it does not include the curative treatment that palliative care is okay with. Okay, hospice is when we know cure is not available, that curative treatments have been tried, they haven't worked, or they've run their course, the disease has run its course. And like there are many diseases where cure is never going to be available. Things like rheumatoid arthritis, sickle cell disease, multiple sclerosis. There is never going to be a cure. Can there be treatments that can prolong life? Absolutely. But there will come a time when all those different treatments may become ineffective. And then the disease is going to take its natural course. Right, palliative care and hospice care is not the same. Palliative care does not always include end of life. Hospice includes palliation at the end of life. Okay? And again, it's that prognosis of 6 months or more. And that's really difficult to determine when is that person 6 months or less of life evident. And it used to be years ago when hospice first started, cancer patients were the main patients that were treated in hospice. And there were not these complex progressive treatments that we have now. Cancer, when I first started nursing, it was the big C. You got a cancer diagnosis and you were going to die. I mean, that was it. You were going to die. Even if you had these horrendous chemotherapy treatments, you were going to die, and shortly. There was none of this. We gave you treatment and you went into remission for 20 months. And then when the disease progressed or reared its ugly head again, nowadays we can give you more treatment, a different treatment modality, a different drug, and you might have 10 to 12 months more of an acceptable quality of life before it turns into, gosh, there isn't much more that we can do to stem this disease process. So in the beginning of hospice, it was easier to say, oh, this patient with this cancer diagnosis, traditionally is not going to live more than 4, 5, 6 months. So it was much easier. Now that there are very complex treatment options, it's much harder to say, oh, this is going to be approximately 6 months. So I think there are many people and physicians included, who don't want to say, I want to go on hospice because I don't know if there's 6 months or more to live. Well, hospice, you can re-up for hospice. If you're still living with this life-threatening illness and it comes to that 6 month point, there are ways to re-enroll in hospice without jeopardizing any kind of of palliative care for those for longer than 6 months. Okay, so hospice is a philosophy. It's not a place of care. There are many people who receive hospice care in the home. There needs to be a designated caregiver that is available in the home to make decisions with and maybe eventually for the patient themselves, but it doesn't necessarily have to take place in the home. Hospice can take place in freestanding hospice. We have a hospice here in Connecticut, the Branford Hospice, which is freestanding. And I do believe there's another in Danbury in the western part of the state. And at one time, there was going to be another freestanding hospital in the eastern part of the state. And as far as I know, that never quite got off the ground with that. But hospice can take place in long-term care facilities, assisted living facilities, group homes, and some hospitals, acute care hospitals, do have specified rooms for hospice care. So it doesn't always have to take place in the home, but that is where the majority of patients are taken care of. So a little history of hospice. It's only been since 1963 that the topic of hospice was introduced here in the United States. It was done at Yale University by Cicely Saunders, who came from the United Kingdom. In 1967, St. Christopher's Hospice was the first hospice in the United Kingdom. 1969, Elizabeth Kubler-Ross wrote her book, or had it published, Death and Dying, which talked about grieving. In 1974, the first hospice in the United States opened, and that was here in Connecticut. It's the the Connecticut Hospital in Branford, Connecticut. 82, 85, 93, there are different healthcare proclamations where Medicare and Medicaid, private third-party insurances, would support and help pay for a hospice benefit. And it wasn't until 2004 that 1 million individuals were cared for by hospice in any given year. So really, if you look at it, hospice is really young here in the United States. And it doesn't always leave a good taste in everyone's mouth. I encourage hospice, and I have encouraged even professional friends, when they've had loved ones who are in the process of a life-limiting illness, to say, might hospice be of benefit now? And even then I got the, no, hospice, we're not ready for hospice yet. But yet, indeed, that loved one went on to die within the next 2 months, totally within a hospice parameter. And I've also had friends who have said, well, we didn't need hospice until the last week. Well, like it was a prideful thing that they could get by without it. But all I think about is, the benefit that the patient and family could have received if hospice had been on board longer than 1 week. But everybody's a little different, and so I just always think that hospice is underutilized as palliative care, as a specialty is underutilized. So, just taking a look at hospice focuses on focuses on caring, not curing. Hospice focuses on caring, not curing. And any terminal illness, any age, any religion, any race, hospice is open to all. And yes, there are a variety of children that do qualify, and hospice is utilized for children at the end of life, not only cancer patients, but but those with disabling genetic anomalies. In the NICU, in the, sorry, that was Zoe, and she just decided to make an appearance here. So anyways, it's used from the littlest tiny, newborns who, may have been born with congenital anomalies that are not compatible with life. And so really end-of-life care and symptom management needs to be, it's essential, for comfort, for the parent, for the caregiver, for the family. All the way to those who, I have a 102-year-old aunt who is on hospice right now. And what's keeping her going, I'm not quite sure, but she is on hospice at this point. So, how is hospice care delivered? Well, it's delivered typically by a family member in the home as the primary caregiver. And as appropriate, that caregiver helps make decisions along with the patient or makes them for the patient if the patient is no longer able to make those decisions. The hospice really centers around the patient and family, and then around that are a variety of services. The physician who is hospice specialist, nurses who make home visits who are dedicated to the hospice specialty, social workers, chaplain service that helps with spiritual care and bereavement, not only bereavement after the loved one dies, but also bereavement while individuals are going through their dying process. Hospice aides that come into the nursing assistants that come into the home, other therapists such as physical therapists, respiratory therapists, whatever the need is, and then volunteers. So volunteers do play a big role in hospice settings, whether it's a freestanding hospice, a home hospice, hospice in nursing home care, long-term care facilities. When I stopped working earlier this year, that was my goal, was to become a hospice volunteer again. And of course, COVID hit, and so everything is on hold because they don't want visitors into homes or nursing homes or into hospitals. So I'm just waiting, not so patiently, but I have to be patient about when I can again go into to be a hospice volunteer. So the services that are provided, again, are provided for the patient in the family as a nucleus. And again, it's whoever that patient decides is the family. It does not have to be a blood relative, as we all know. So the services that the hospice provides, they're managing patients' symptoms and any pain that may be involved. They assist the family members with emotional, psychosocial, and spiritual aspects of dying. They provide medications and medical equipment for the treatment of the symptoms of the disease. Hospice does not cover, like if you're taking a statin, if the patient is taking a statin or takes an over-the-counter vitamin D, they're not going to supplement that particular medication. But if it's a medication for shortness of breath, for cough, for pain, for hiccups, pain management, anything like that, hospice will furnish. Hospice will instruct family and family caregivers in how to manage that individual patient. They will come into the home and help develop that plan of care and teach the caregiver how to best manage that. Hospice also makes short-term inpatient care available as necessary. And it's usually for two different reasons a patient may be readmitted to the hospital. One is for respite care, when the caregiver needs a break. Okay, maybe it's just the caregiver would like to go on a short vacation with the rest of the family, or there's a family event that the caregiver would dearly love to go to, but feels they can't leave the patient home alone. So it may be able, the hospice service may be able to arrange short-term respite care, either in a long-term care facility, a rehab facility, in an acute care hospital, 3 to 5 days, to give that caregiver that necessary break. The other time that home hospice, a patient may be admitted to an acute care setting would be if there's a symptom that becomes just too difficult to manage at home at the present time. It could be shortness of breath. It could be pain, where the medications need to be changed very quickly, and it's just not possible for the family member or the hospice nurse to be there for those quick changes. And so the patient may be admitted into the acute care setting until that symptom can be better managed, a new regimen set up, and then they can go back home or to their long-term care facility. And then hospice also offers grief support and counseling for surviving family members and friends. And that takes place usually up until through the first 12 months of after the death of the particular hospice patient. So again, lots of things to consider when you think about palliative care and then hospice care. So, talking with your healthcare provider as a caregiver or the patient, their communication with the patient, with yourself and the healthcare provider can be difficult. And when I say you, it can be either your family member who's the patient or the caregiver. You might not understand some of the terms and you might be hesitant to ask for explanations. You may feel rushed during a physician appointment. I know in the office I just worked for, appointments were for 15 minutes. We ran late all the time. Sometimes people weren't very happy about that. But how do you talk about symptom management, end-of-life decisions in 15 minutes? It's really hard. So the patient or the caregiver may feel that they know that they only have a short time and may feel rushed. The family or patient may feel overwhelmed by the information, the diagnosis, the prognosis, or treatment options that are being offered during that appointment time. So it can be very difficult to feel comfortable in asking questions and communicating with the healthcare professional. So it's okay for the healthcare for the caregiver or for the patient to say, wow, you've given us a lot of news here today, and we really need to think about this before we hear more information or before we decide on what's next. So let's go home and think about this and have another appointment next week or in 2 weeks. It's okay to not decide everything on that first appointment when you find out what this new diagnosis is and what it means. So some of the questions that as a caregiver or a patient, I would hope that you would want to ask, or these are some things that you might want to ask your healthcare provider. And this might be your primary care physician. It might be the specialist, like the oncologist that you've just gone to. What is wrong? What is the disease name? What is the diagnosis or the disease or this condition called? Is it a life-threatening or life-limiting chronic disease? What's happening to me? as the patient. Give me a general picture of what this is. So many times you get the diagnosis of lung cancer. Well, what does that mean? What does it mean for me? Where is it? What's the prognosis? What does this mean? What is my future going to look like? What's the natural progression of this disease or condition? If I did nothing, what would happen to me? Are there any treatments available for this condition? What are the goals of those treatments? Is it for cure? Is it for control? If I'm a diabetic, treatment options are not cure for the most part, unless there's pancreatic organ transplants. So mostly they're just for control. Rheumatoid arthritis, it's control of that disease. It's not a cure. Cancer, it may be a cure. Okay, liver disease, it may be a cure. Or is the treatment not just, but is it for control of my disease? As a patient or family member, I would want to know what are the risks and benefits of each of the treatments you're talking about, whether it's drugs, whether it's surgery, whether it's psychological counseling. What are the risks and what are the good points and what are the bad, not so good points of this particular treatment? Who will be my doctor if I decide to take this treatment? Will you still be my doctor? Or do I have to go to a specialist who I don't know? Or if I don't want treatment, who will be my doctor? Will you continue to be my doctor? Those are real concerns that many patients have as to what's going to happen to me. And I've developed a relationship with my primary care or with my specialist. And will that person still take care of me if I decide to have treatment and if I don't decide to have treatment? What about my quality of life? What happens with the natural disease progression and my quality of life? What happens to my quality of life with all of these treatments that you're talking to me about? Many people have heard that chemotherapy is horrible and you puke your guts out. Well, yeah, 45 years ago when I started nursing, you did puke your guts out, but things have changed so much. But people still may have heard stories about the horrible things that happen with some of the treatments. So, to be asking questions, what's going to happen with my treatments? How is that going to be managed? What's going to happen to me during treatments? And how can I still maintain a quality of life, whether it's going to work still, whether it's having contact with my family, my children, my grandchildren, my friends, in my environment. And then to ask your physician who's addressing your new disease process, do you know about palliative care? Is it available here in my city, in my town, in my network of healthcare? Okay, those are the kinds of things that as a caregiver you might want to be thinking about. The other thing as a caregiver is ask for help, whether it's from the physician who's taking care of you and is giving you this diagnosis, or one of the team members in that particular office. A lot of times the registered nurse, is there to help educate and help guide. There may be a nurse navigator that can help through this maze of all these different things, and dietitians and social workers and psychologists and treatments and chemo. And so there may be a nurse in the office or a nurse navigator in the system. Sorry. Sorry. She's very needy tonight. She went to the vet today and has had her shots, and I think she just wants to have a little loving time with me tonight, which she will get when we're done. So I'm coming to the end here, and I've probably talked too much or too fast, but the kind of the takeaway points that I want to leave you with today is that caregiving is hard work. No matter what the diagnosis or the age of the patient or the caregiver is, it's hard work to care for your loved one. Caregivers must take care of themselves, which I know Wendy is just stressing and that's why she has developed this website, because you need to take care of yourself to be able to take care of your loved one. Palliative care helps treat the symptoms of disease and the symptoms associated with treatments of that disease or condition to improve quality of life for the patient and for the caregiver and loved ones. Hospice helps treat symptoms of that disease and to improve quality of life at the end of life, during that last 6 months of life. Okay. And finally, as a caregiver, as a patient, you need to know there is no stupid or silly question that you can ask your healthcare provider or their office, or ask the office nurse. Believe me, as an office nurse, I have heard everything. There is no stupid or silly question to ever ask your healthcare provider. So with that, Wendy, if you're still there, do you want to open this up for questions, or are there specific questions that might be out there?
Yes. So we don't have any questions in the chat. If you have questions, please put them in the chat, and Lynn can answer them. Lynn, thank you so much. That was really good. I do have a couple of questions of my own on the behalf of caregivers. So if my loved one is on chemotherapy, can they still have palliative care?
Absolutely. Because palliative care really can start at the very beginning of these diagnoses. Unfortunately, it's usually not introduced at the beginning, and it's usually, unfortunately, towards the transition to end of life, when treatment kind of stops being curative and just kind of we're putting the plug in the finger in the dike kind of thing. So unfortunately, that's usually when palliative care is consulted. But no, you can receive treatment with palliative care.
Good. No, thank you. And if I'm a caregiver, how would I tell my loved one about palliative care who may think palliative care is synonymous with hospice care?
And I think that's a good point, Wendy, because many people think they're the same, and they aren't the same. Palliative care is just taking care of, it's symptom management. So even if I have a headache or I have arthritis, I have chronic arthritis in really one of my ankles. So to palliate that symptom, when it hurts, I take Tylenol. That's palliating that particular symptom. That's never going to go away. It's bone on bone. Ankle transplants are still in their infancy, or not transplants, joint replacements are still in their infancy. I'm going to probably die with arthritis in my ankle, but I'm going to palliate it. So sometimes it's Tylenol, sometimes it's a heat pack. That's palliative care in its very simplest form. I mean, it's not a life-threatening illness. It's not a life-limiting, well, sometimes it's life-limiting. I don't go skiing, I don't snowboard anymore. But, so it's really, that's a very simplistic example, but it still is palliation of symptom management. What do you do when you're nauseous? When you've eaten something that just doesn't agree with you, you've got acid indigestion. So you drink ginger tea, or maybe peppermint tea, or you take some Tums, or you take some ginger ale. or you've got some little ginger bites that you take for that nausea and upset stomach. You're palliating nausea. So again, those are very simplistic, non-life-threatening examples, but I think that they're examples that you might use in, if my loved one, if honey, you've got indigestion, what do? We give you different things. We try different things. We don't use that hot sauce anymore. So maybe to start that discussion as a very simple, what do we do to take care of ourselves when we have these symptoms? What do you do when you have constipation at home? What do you do when you have diarrhea at home? We all have our little things that we palliate with. Somebody with IBS and irritable bowel syndrome with diarrhea might eat rice every day. That's palliating that disease process. That's because it's for symptom management. It's not curing the disease. It's simply for symptom control. So I think as a caregiver, I might talk to my loved one about some of these maybe simplistic, how do we take care of ourselves with a little nausea, a little arthritic pain, a little diarrhea, what do we use for constipation? Those little home remedies that we use. And then you might be able to progress then to more severe symptoms of that disease process: fatigue, muscle weakness, bone pain, pain in general, whatever. Does that make sense?
Yes. Yes. No. It's a lot of stuff. I have another. So if my love,
you're kind of a little garbled. Okay? Yep.
Can you hear me now? If my loved one's on chemotherapy, do I have to talk to the oncologist about palliative care, or can I talk to my primary care doctor?
Primary care. The question is primary care doctor versus my primary care doctor versus my oncologist. And I think many oncologists are very aware of how to treat symptoms. And so you may want to start with that oncologist because that's the disease process and that's the treatment that is giving you the different symptoms. And in my own personal experience, what I have found is the oncologists I have worked with have done their best to help palliate different symptoms. And then they will refer to palliative care or pain management team as the symptom becomes bigger than what they know how to manage. Usually there's not an ego involved. It's just, I've come to the limit of my knowledge and that patient needs more expert care than I can give them. I'm the expert on how to use the chemotherapy, but I need an expert in how to manage that symptom or that pain. So I think I would talk to the oncologist because that's the disease process that's causing the symptoms.
Okay, now thank you for that. And I know we have a couple of healthcare professionals watching. What role do they play in helping caregivers?
Well, I do think that, again, it's very difficult to separate palliative care from hospice care with many individuals. They see them as one and the same. So I think just education, just to talk about the difference between, hospice care, which may not be appropriate or may not be appropriate, and managing symptoms, and also talking to the healthcare team, the providers in, what is their take on palliative medicine, and when is that point that they're willing to refer to palliative medicine. And I mean, I would have no qualms to talk to a patient and say, have you asked about a palliative care consult to talk about greater pain relief? And if they're saying, well, no, I really don't want to bother the doctor, I have no qualms in going to the physician and saying, I was talking to Jane Doe, during her clinic visit today, and the pain management that we're doing just doesn't seem to be working. What do you think about a palliative care or a pain management consult? And introducing it that way to kind of being an advocate for that patient, because my goal as the nurse is to be an advocate to help them maintain the best quality of life for the longest time possible. And if I can do that by kind of pushing things along a little bit, which as nurses we do all the time, and we just kind of, gee, what do you think about, because I can't prescribe or I can't make that referral, but I can certainly advocate for my patient.
Yeah, no, it's really good. My audio. But we're going to wrap up. Thank you so much, Lynn. This was great.
It's been my pleasure. Hello, everyone. Enjoy this wonderful weekend coming up.
Yep. Thank you for joining. If anyone has any questions, please put them in the chat and Lynn can answer them after. Thank you and have a good night. Bye.
Bye.